And in today's session, I'm going to talk about oral cancer. Oral cancer are one of the leading cause of morbidity and mortality in India. Are you aware of that around 3 lakh of patients suffer from oral cancer worldwide? And that too, most of them are there in the developing country, around 2/3 of them. And that too, most of the cases are seen in Indian subcontinent. Now, this is basically because of the lifestyle of the patient, habits of the patient, like tobacco-related habits, smoking habits, less amount of education in these patients, and the treatment modalities that are available, and early screening process which are not there as compared to the developing countries. And to add to it, sadly, most of the cases that are identified in Indian subcontinent are diagnosed at a very late stage, wherein around 20 to 50% of them are at last stage, that is stage 3 and 4, wherein the year of survival is not more than 5 years. Now, let's move on to the anatomical subunit of oral cavity. Now, you must be wondering, why are we going to talk about the anatomical subunit? Now, we need to talk about the subunit because oral cancer occur at specific site depending upon the etiological factors used. Now, basically, the oral cancers are broadly divided into those that occur in the floor of the mouth and the tongue, and those that occur in the buccal vestibule and the dentoalveolar segment. Now, in the developed countries, the cancer that occur is more commonly in the tongue and the floor of the mouth. Now, this is mainly because of the smoking tobacco and the alcohol, wherein as in the Indian subcontinent, since the use of the chewing tobacco and arganat, the gingivobuccal cancer is more common. That's the reason why we need to know the anatomical subunit. Now, with this, let's move on to the etiological factors of oral cancer. To begin with, tobacco, the most common etiological factor. The nitrosamine that is released, which is a byproduct of nicotine in tobacco, is the main carcinogenic agent. Now, this carcinogenic agent, it altered the DNA repair of the cell, wherein abnormal DNAs can cause multiple growth and result in the tumor. Now, alcohol. Now, alcohol has 3 basic effects. The first is it is a local irritant. Secondly, it is a solvent, that it provides penetration of the carcinogenic agent into the mucosa. Thirdly, it alters the DNA repair. Now, tobacco and alcohol have a synergistic effect, that is, when they are used together, their bad effects are amplified, resulting in more destruction and more chances of getting oral cancer. Now we come to viruses. Human papilloma virus is seen to be an important etiological factors in squamous cell carcinoma, wherein the mutant variety, the high potent variety of human papilloma virus 16 and 18 is most commonly seen to cause oral squamous cell carcinoma. Now, in Indian subcontinent, the etiological factor without the mention of betel quid is incomplete. Betel quid and arganat in form of pan, which is nothing but betel quid, wrapping, lime, spices, betel nut and tobacco. Now, all of these agents causes alteration in the mucosa. They causes permanent alteration. If it is treated early, these are called as premalignant lesion and conditions like leukopenia and oral submucous fibrosis, which has higher chances of cancer development. Last but not the least are the constant chronic trauma to the mucosa can be because of the dental causes. That is, it could be because of poor oral hygiene, a sharp tooth, an ill-fitting denture, or a sharp crown or bridge can also cause constant chronic trauma to the mucosa, which could eventually cause dysplastic changes in the oral mucosa. Now, let's move on to the spread of squamous cell carcinoma in the oral cavity. Now, the spread can take place by 3 routes. One is local infiltration, that is, from the primary site, the tumor can spread to the local tissues like bone, soft tissue, perineural spread, or vascular spread. The second is through the lymphatic spread. Now, lymphatic is the LOC of our body, that is the line of control of the body. It is the first site where the infections are tackled in our body whenever you get prone to any kind of infection. So, lymphatic spread can take place, can metastasize. If a tumor involves a lymph node, from the lymphatic channel, the regional lymph node can also get affected. Now, the third is the spread of the tumor through the bloodstream. That is the distant spread. That is, a tumor emboli can spread through the blood to distant part of the body. Let's move on to the oral premalignant lesions and condition. As I mentioned earlier, these are the condition and lesion wherein the chances of cancer development is very high. So what do I mean by a premalignant lesion? It is an altered morphological state of a mucosa which has a chances to develop oral cancer compared to the normal mucosa. So there is morphological alteration of the tissue that take place. It is a premalignant lesion. Example is leukoplakia, erythroleukoplakia and erosive lichen planus. So what is premalignant condition? Now premalignant condition, as the name suggests, is the generalized state of the body wherein the body state is such that it is more prone to develop cancer. Example is oral submucous fibrosis. Now why do we need to know about these conditions? Now these conditions are reversible condition. If it is diagnosed early, we are able to treat the patient and reverse it and prevent cancer development. So these condition and lesion have to be educated to the people so that they know that if they can see these kind of changes that are taking place in their oral mucosa, they can report to us early and we can treat them with a better modality. Now, leukoplakia is nothing but a white lesion in the oral mucosa which cannot be rubbed or scraped off easily and cannot be characterized into any other definable lesion. Whereas erythroplakia is nothing but a red patch or a plaque. In other words, erythroleukoplakia can also occur, which is a combination of lesion or a mixed lesion of both red and white condition. Now, what are the treatment of this leukoplakia? If the leukoplakia is homogeneous, we have a conservative approach. That is, tell the patient to stop the habit, remove any kind of irritant that is present, and do a proper observation. Call the patient for a periodic follow-up. Also ask the patient to take multivitamins and iron supplements to enhance healing. Now, in case of heterogeneous leukoplakia or in leukoplakia which are at a site of a higher risk or erythroleukoplakia, removal of the offending agent is a must. That is stoppage of tobacco, alcohol or any kind of ill-fitting dentures, trim the tooth and all. Use of a chemopreventation. Now, chemopreventation is nothing but medications that are used to cure, or these are basically multivitamins or antioxidant which are used to treat this morphological alteration like carotenoid, beta carotene, lycopene, vitamin A, vitamin E. These are the chemopreventive agent. Then surgical management. Those palpable lesions of leukoplakia and erythroleukoplakia has to be surgically removed. Now when you're removing these lesions, you have to remove at least 1 mm of margin, free margin of these lesions and send for histopathological examination. They not only help to eliminate the disease but also help us to diagnose their margins, whether the margins are having dysplastic changes or not, whether these lesions are progressing towards malignancy or not. If it is, then we have to offer other treatment modality. Now, oral submucous fibrosis. As I mentioned earlier, it is a generalized state of a body. Here, the hallmark of oral submucous fibrosis is there is juxtaepithelial deposition of the fibrous tissues in the parts of the oral cavity, pharynx, upper third of the esophagus. Now the clinical picture depend upon the grade of oral submucous fibrosis. Now, based on this, these oral submucous fibrosis are graded into 4 groups. Group 1 is an early stage or the initiation. There is no limitation of mouth opening in this case, wherein the mouth opening is more than 35 centimeter. Patient just complain of a generalized stomatitis, just inflammation of the mouth. He will start feeling discomfort when eating spicy and cold food and sour food. Now, group 2 is interincisal distance is decreased because of the juxtaepithelial inflammation that is starting and fibrous bands are slowly getting accumulated. Okay, the interincisal distance is 26 to 35 millimeter. Here you would see the blanching because of the fibrin getting deposited. The vascularity is deprived and you will see blanching of the mucosa. Now in group 3 is a moderately advanced case wherein the intraincisal distance is 15 to 25 millimeter. Here you will actually palpate, you will actually feel the bands when you palpate the oral mucosa, the buccal mucosa, the upper and lower lip, the pterygomandibular raphe. You could feel the thick fibrous band at this stage. Now group 4 is further divided into 4A and 4B. Now 4A is a severe condition wherein the interincisal distance is less than 15 millimeter. There is an extensive fibrosis of all the oral cavity and 4B is an advanced stage which is associated with the malignant changes. Now, how do you treat oral submucous fibrosis? Now, strict discontinuation of the habit is a must. You ask the patient to have a bland diet, jaw stretching exercise to remove these fibrous bands, nutritional supplements like iron, multivitamin and protein, because since the mouth opening is decreased, patient is not able to tolerate food, spicy food and any kind of hot food. The intake is less, so you need to provide nutritional supplement. Then, depending upon the stage of oral submucous fibrosis, whereas it is early stage, medical management is sufficient. In advanced stage, you have to offer surgical management. Now, in case of an early stage, medical management include use of steroids. Now here we use hydrocortisone. Now why steroids? Steroids are basically anti-inflammatory. So they take care of the juxtaepithelial anti-inflammatory reactions that is taking place in oral submucous fibrosis. So you could give hydrocortisone 1.5 cc mixed with, you can have 1 ml of 2% lignocaine, pain lignocaine, and inject into the fibrous gland. Here you give intralesional injections. You directly have to inject into the band. You have to use an insulin syringe which has a small needle and a smaller diameter just to inject, submucosally inject into the glands. Around 0.2 ml of solution is deposited at the various site. Now the next is use of enzymes. Now enzymes like hyaluronidase. Now why hyaluronidase? Now this hyaluronidase causes hydrolysis of hyaluronic acid, which is the prime basic cementing material of the mucosa. So it basically causes penetration of the agent to bring about fibrinolysis. That's the reason why we use enzyme. It also helps to break down the collagen fibers and the fibroblast, that is causes fibrinolysis. Now you use hyaluronidase 1500 international unit, you give intralesional injection. Most of the time you use these in case of combinations like hydrocortisone along with hyaluronidase and local anesthesia is used. The other treatment modality is cardiovascular drugs like pentoxifylline is nowadays used. 400 milligram tablet is given BD for 3 months. Now they show that these pentoxifylline along with microvascular dilatation property, they also affect the fibroblast, that it causes fibrinolysis and alter the fibroblastic cells and decrease the fibrous band production. The other things that you could use is antioxidant and vitamins and minerals like vitamin A, vitamin E, carotenoids. Lycopene can be used as an antioxidant to decrease the free radical and decrease the fibrous formation. Then comes the use of placental extract, the aqueous human placental extract. Now this is basically used to causes, it has her property of stimulation and regeneration. It causes regeneration of the altered mucosa. So you could use placental extract. So now when you're giving an injection, okay, basically you call the patient twice a week. So one time you could use hyaluronidase along with hydrocortisone with LA, and the second time you could use placental extract to have a synergistic effect of both the injection modalities. Last but not the least, studies are being carried out for the use of interferon and gamma on the treatment of oral submucous fibrosis, immunized milk powder and turmeric, natural substitute which can be used to decrease the fibrous in case of oral submucous fibrosis. Now, this slide show you a diagrammatic, or you can say a schematic flowchart representation of various stages of oral submucous fibrosis and how you will treat them. Okay. Now keep in mind, for all stages, there are two things that you need to do is start the patient on iron supplement like Dexorange or Hemab syrup. Secondly, an antioxidant capsule is a must. You need to give it twice a day for 3 months. It could be anything like Antoxin, Revab. These are all will decrease the free radical. Then, in case of stage 1, topical mouth rinses of like triamcinolone gel can be used, or crushed dexamethasone tablet in 20 ml of water can be used as a rinse to decrease the stomatitis. Now, newer drugs are also available, as I mentioned earlier. Pentoxifylline 400 mg twice a day can be used for a month, or lycopene 16 mg can be used for 3 months in early stages. In stage 2, when you start to feel the band and you can see the blanching, then you start with intralesional injection. As I mentioned earlier, you could use a combination like a hydrocortisone along with hyaluronidase and lignocaine can be injected once or twice a week for 3 months or for 6 weeks. Or you could do is hyaluronidase can be used with placental extract 30 ml, okay, twice a week for 6 weeks. Any combination is used to correct these conditions, but jaw stretching exercise physiotherapy is a must for all of them. Then in case of stage 3 and stage 4, no medical treatment is required. You have to opt for surgery. Now surgery is basically removal of this fibrous band. Okay, it could either be done with blade or lasers. But keep in mind that once an OSMF is always an OSMF. So you have to be very judicious when you're opting for a surgical modality. Now whenever you cut something, the healing takes place in form of fibrosis. So when you're cutting a fibrous band and leaving it like that, again there will be another fibrous band when healing will take place. So you need to keep something in that area so that fibrosis doesn't develop. So there are materials that you could use to release the fibrous band and place on top of it, like buccal pad of fat can be placed, which they say cannot undergo fibrosis after the healing. It epithelializes in 14 days and fibrosis doesn't occur in that tissue. You could use a collagen sheet or a silicone sheet to prevent, again, fibrous band formation. You could use local flap like nasolabial flap can be used in advanced cases wherein there is a specific indication and you can treat these kind of patient to gain. Basically the surgery is to increase the mouth opening, nothing else. But after any kind of surgery, physiotherapy is a must, either with the use of mouth opening exercise, mouth opening appliances, or by simple use of incremental increase in ice cream sticks. So whatever treatment modality you opt for, physiotherapy and jaw stretching exercise is a must. Now we move on to the chemopreventive agent that I use to treat the premalignant lesion. As I was mentioning earlier, these are nothing but retinoid, beta-carotene, vitamin C and E and natural agent, which they basically causes the keratinization of the epithelium is decreased. It try to make the mucosa normal, decrease the keratinization, because in a premalignant lesion keratinization is increased. So these agents will decrease the keratinization process. Now let's move on to the diagnosis and staging of the oral cancer. Now diagnosis always begin with a clinical examination. So most of the time these cancerous lesions will appear as a non-healing ulcer. Now these ulcers can have an irregular margin, they could be indurated, or sometimes they could have an exophytic growth. These are the characteristic feature of a tumorous or you can say a cancerous lesion. Sometimes the base of the ulcer is hard and it is attached or fixed to the underlying tissues. Now if there is involvement of the gingivobuccal fold, there will be obliteration, exophytic growth will be there. There could be involvement of dentoalveolar segment, the tooth may become mobile and there will be necrotic non-healing socket can be seen. Wherein in case of the cancers of the oral cavity and tongue, the tongue mobility is restricted, hypoglossal nerve paralysis is there. Wherein speech, deglutition, everything is hampered in that scenario. So you need to keep all these clinical features in mind. If there is involvement of the infratemporal fossa because of the tumor, there is trismus. But you need to keep in mind that to evaluate this from oral submucous fibrosis, because trismus can also be because of oral submucous fibrosis. And almost 50% of the oral submucous fibrosis have a chance to develop into cancer. Now, your clinical finding is not sufficient. You have to aid it with other diagnostic aid like biopsy. So whenever you are doing a biopsy of a tumorous lesion, along with the tumor mass or the ulcer, you have to take a normal margin of the adjacent tissue. At least 1 to 2 ml of the normal margin you have to see, because this will tell you the dysplastic changes, whether they are penetrating into the normal tissue or not. At the same time, do not take your biopsy lesion from the necrotic area, because in the necrotic area, definitely you will see just necrosis in dead cell. You will not see the proliferation or dysplastic changes in that. Then you have to aid your clinical finding, your histological finding along with the imaging modality. Just clinical finding is not sufficient, because imaging will help you to know the extent of the lesion, whether it is just a superficial lesion or there is involvement of bone and soft tissue surrounding it. Now what imaging can we do? Most of the time, the oral cancer are around the perimandibular region. So an OPG is sufficient in that case, but it has certain drawbacks, like the anterior lesion cannot be properly assessed in case of an OPG. And in early lesions like mandibular erosions and all, you cannot assess an OPG. In that case, you have to do a CT scan. So any kind of hard tissue lesion, you will offer a CT scan. And any kind of a soft tissue lesion, you will offer a MRI. Like if there is involvement of muscles or there is ulcer of the floor, non-healing ulcer or cancer of the floor of the mouth and tongue, in that case, you have to do a MRI. Nowadays, newer advanced diagnostic imaging technique like PET scan, bone scintigraphy are available, but they are very expensive. Eventually, as the field advances, you might be able to use them. Now, the other treatment diagnostic aid is FNAC, fine needle aspiration cytology of the neck node. Now here, as I mentioned, the cancerous cell can spread through lymphatics, that is through the lymph node and their lymphatic channels. So there are chances that lymph nodes are involved. So you cannot cut open and take a biopsy of a lymph node. It's a big no, because you will directly spread the cancerous cell to the adjacent areas and can even spread into the blood and cause distance metastasis. In that case, what you will do is you will do FNAC, fine needle aspiration cytology of your node, and identify whether the metastasis is present in the node or not. Secondly, this is basically used to give you an idea of what all lymph nodes are involved, and appropriately you can plan your treatment. Now, let's move on to the clinical examination of lymph node, which is a very important role in the diagnosis as well as the treatment planning and prognosis of the oral cancer. Now, American Joint Committee has divided the lymph node into 7 levels. Level 1 is divided into level 1A and B, wherein A is node in the submental triangle, that is submental group, and level 1B is node in the submandibular triangle, that is the submandibular group of lymph node. Level 2 is the upper jugular node, that is from the skull base to the bifurcation of the carotid. Now level 2 is also further divided into 2A and 2B by spinal accessory nerve. Okay, 2A is the posterior superior part, whereas 2B is the anterior inferior part. Now level 3 is nothing but the middle jugular group of node, which is from the carotid bifurcation to the omohyoid. Level 4 is the lower jugular group of lymph node from the omohyoid to the cervical, that is the clavicular area. Level 5 is the node that are present in the posterior triangle. Level 6 is the node in the anterior triangle, that is the central compartment group, and level 7 is the upper mediastinal group of lymph node. Now, why do we need to know these level of lymph node? Because now all primary tumor have their specific site of lymphatic drainage. Like tumor in the alveolus more commonly drain into the submandibular region, submental region, and to the upper jugular region. So because of this, since they have a specific pattern, so if the tumor is present in a specific region, we have in mind that these lymph node will be available. So how you will confirm that they are involved? By doing FNAC. So once your FNAC is confirmatory, you will level your lymph node that are involved, and accordingly you can plan your surgical treatment, that is the neck dissection, which we'll see later in the session. Now this slide show a diagrammatic representation of the level of cervical lymph node that are involved. What I've explained you in a diagrammatic format you could see in this photograph. Now let's move on to the nodal metastasis. Nodal metastasis depend upon 4 factors. Okay, one is the location of primary lesion, the size of the lesion, the T stage of the lesion, and histomorphologic factors. Now, before we start with the TNM staging, you need to know what T stands for. T is the primary tumor site, and N is nodal metastasis, wherein M is distance metastasis. T and M staging are a very important part of the diagnosis of oral cancer. Now, TNM staging will help you to stage your oral cancer, and once you stage your oral cancer, you know what type of tissues are involved, and accordingly you could plan your neck dissections. Okay, now here TX stands for primary tumor lesion which cannot be assessed, whereas T0 there is no evidence of primary tumor lesion. TIS is carcinoma in situ, wherein T1 stands for when the lesion is 2 cm or less in diameter. T2 is when the lesion is more than 2 centimeter but less than 4 centimeter. Wherein T3 is where the lesion is more than 4 centimeter. Now T4 is further divided into T4A and B. T4A are those that involve the cortical bone and extend into the muscles and tongue, sinus and face and skin. Wherein T4B, there is involvement of the spaces, masticatory space, base of the skull and the internal carotid artery. That is, more vital structures are involved in T4B cases. Now, N is nothing but regional node metastasis, wherein NX stands for regional node cannot be assessed, and N0 is there is no regional lymph node metastasis. Now, N1 is single ipsilateral. Ipsilateral is nodes that is present on the same side, are metastasized and they are less than 3 centimeter in diameter. Whereas N2 is further divided into A, B and C. Okay, whereas N2A is single ipsilateral node which are more than 3 centimeter but less than 6 centimeter. 2B is multiple ipsilateral node which are not more than 6 centimeter. And C are bilateral or contralateral nodes which are not more than 6 centimeters. Now N3 is metastasis in the lymph node which are more in diameter, more than 6 centimeters in diameter. Now this is a diagrammatic representation of the node metastasis, that is the end staging of the neck lymph node. You could appreciate N1 that is 3 centimeters, N2 3 to 6 centimeters, N2A ipsilateral, N2B multiple node not more than 6 centimeters, N3, N2B 6 centimeters ipsilaterals. Now let's move to the M staging. M staging, as I mentioned earlier, is nothing but distance metastasis. MX stands for distance metastasis that cannot be assessed, whereas M0 is no distance metastasis. M1 is distance metastasis is present. Now this slide shows a flow chart wherein you could stage your oral cancer depending upon your T and M staging. Wherein if there is TS, that is no tumor can be assessed, at N0 then you stage it at stage 0. If there is T1, that is tumor size is less than 2 centimeter, and it is N0, then it is stage, but there is no lymph node involved, then you will stage it at stage 1. And T2 is when the tumor size is more than 2 centimeter but less than 4 centimeter and regional lymph nodes are not involved, then you will stage it at stage 3. Okay, if it is T3 more than 4 centimeters and there are N1, that is ipsilateral nodes are involved, then stage 3. Any of the tumors wherein the nodal metastasis is present, that is N2, that is either ipsilateral node are involved or contralateral or bilateral nodes are involved, which are between 3 to 4 centimeters or 6 centimeters, then it is stage 4A. Any primary tumor with N3 node metastasis, it is staged as stage 4B. Now stage 4A are operable cancers, stage 4B are inoperable cancers, whereas stage 4C are metastatic cancers. Now let's move on to the management of the oral cavity cancer. The management is very critical because you are trying to remove the cancerous tumor along with the metastatic spread that has occurred in the regional lymph node and the surrounding tissue. So a lot of amount of tissue is lost. So for a surgeon, you have to keep in mind that you are removing the cancerous tumor. At the same time, you have to restore the patient with facial aesthetic as well as the function. So here the management involves a multidisciplinary approach, wherein you require an oncosurgeon, a radiotherapist and a medical oncosurgeon, medical oncologist also. Along with that, a supportive team of speech therapy, physiotherapy, a dental team, a maxillofacial surgeon is required to assist a prosthodontic to rehabilitate the patient. Now, early oral cancer can be treated either by surgical treatment or radiation therapy. Now, there are specific indications for both of them. Like radiation therapy is for those patients who do not want to undergo surgery, either because they are unfit for general anesthesia or because of the surgery there will be a cosmetic and functional defect. So you will offer a radiation therapy either in form of direct radiation therapy or brachytherapy. Now brachytherapy is nothing but you will implant the radiation implant into the lesion. so that the surrounding soft tissue, muscles, nerves, lymphatic glands are not affected because of the radiation therapy. Now, but there are specific indications for that. That is the lesions which are less than 3 centimeter in primary size. In that case, we could offer a brachytherapy. Otherwise, we have to go for a direct radiation therapy. Now, the radiation therapy is not only a treatment modality for oral cancer, but they can also be used post-surgically. Now, when can we use post-surgically? In case there are multiple lymph nodes are involved. There is gross tissue involvement, wherein after surgery also there is some amount of tumor tissue available, so you have to do a radiotherapy after that. In that case, when there is involvement of the vital structures like skull base involvement and all, in that case you have to opt for radiation therapy. Now, surgical management. There are certain things you have to keep in mind in case of surgical management, that is the margin of the lesion. Whenever you are resecting an oral cancer or a tumorous lesion, you have to keep a 1 centimeter of tumor-free margin, is always. But at the same time, when you're removing that, you have to preserve a 1 millimeter of margin of the inferior border of the mandible to prevent any pathological fracture later on. Now, more modality that I use to do this resection. Either you could use laser, you could use cautery or a scalpel. The result are the same, whatever you use. Okay. Then the approach to the oral cavity. In case of small anterior lesion, you could have a perioral approach. In case of posterior lesion, like the posterior buccogingival sulcus, you can do a lip split technique. Then you could do a pull-out operation in case when there is floor of the mouth and the tongue is involved. In case there is gross involvement of the mandible, you could offer hemimandibulectomy. Now, marginal mandibulectomy. Now, these are done in lesions that have reached close to the mandible but does not cause gross involvement of this. You will remove a 1 centimeter of safe margin, keeping in mind that 1 centimeter of the mandible is preserved to prevent post-operative or pathological fractures. Now, indication of marginal resection or types of marginal resection. Either you could do a horizontal mandibulectomy or alveolectomy, lingual plate excision or a buccal plate excision, depending upon the site of the tumor and its approach. Now, contraindication of marginal resection is they are contraindicated in edentulous mandible wherein the height is already removed. So, if you are removing the tumor mass, you are removing 1 centimeter of normal margin. There is nothing left behind. So, in case of edentulous bone, it is a contraindication. Post-radiation, avoid resection because it can undergo osteoradionecrosis. And if there is cross perimandibular spread, rather than resection, offer hemimandibulectomy or a segmental resection. Now, management of locally advanced oral cancer, that is stage 3 and stage 4. They are divided either into composite resection or segmental resection. Now, composite resection is nothing but removal of the tumor mass along with vital hard and soft tissue surrounding it, like muscles, nerves, arteries, internal jugular artery and all that. That is composite resection. Segmental resection is further divided into hemimandibulectomy, whereas half of the mandible is removed, or segmental mandibulectomy. That could either be posterior segment mandibulectomy or middle segment mandibulectomy. Okay, let's move on to the classification of neck dissection. Now, treatment modality of oral cancer is incomplete without talking about the neck dissection because it is the surgical treatment modality. Okay, but there are certain terminologies that you need to know. First is radical neck dissection. As the name suggests, it is radical. Remove everything that comes into your way to treat the patient. Here, in this case, all the lymphatic and lymphatic channel up to level 4 are removed because most of the oral cancer can spread till the level 4 lymph node. Along with that, non-lymphatic tissues are removed, that is sternocleidomastoid, spinal accessory and the intrajugular vein, because distance metastasis can take place because of these three involvement. Now, modified radical neck dissection. Now, in this neck dissection, you will remove the lymph node and lymphatics up to level 4 and you will try to preserve any of the three structure that we used to remove in radical neck dissection. Okay, like either you will remove spinal accessory nerve, preserve the internal jugular and sternocleidomastoid, or any of one or two you will remove and try to preserve the other one. That is modified neck dissection. Now, selective neck dissection. Now, it is basically you remove the area of the tumor and selective lymph node, not all the lymphatic. You will try to preserve the lymphatic also. You will just try to remove those selective lymphatic which have higher chances to become metastatic. So selective lymph node, and you will try to preserve all the non-lymphatic structure, that is spinal accessory, internal jugular and sternocleidomastoid. You will not remove them, you will try to preserve them. Then extended neck dissection. Extended, as the name suggests, it is more radical than the radical dissection. Here you will remove lymphatic as well as non-lymphatic structures which were not addressed in radical neck dissection. That is, you will extend your neck dissection. Now these are basically done in advanced lesions where the metastasis could be into the distant areas. Now, adjunct treatment are also required in stage 3 and stage 4 of the oral cavity cancer. Now, these adjuvant treatment are in form of chemotherapy and radiation therapy. Now, they are broadly divided into two categories. High risk lesion, these are T4 lesion, multiple nodes are positive, perinodal extension is there and cut margins are positive. In that case, you have to offer chemotherapy like use of drugs like cisplatin 100 mg. Okay, 2 to 3 weeks you have to give them. Then or cisplatin 20 to 40 mg twice weekly. Or in case of a low risk lesion, you can offer radiation therapy 57 to 67 query 30 fraction or per 6 weeks. Now, criteria that are suggestive of inoperable cases wherein there is fixed neck node are present, that is fixed neck node adenopathy is present. There is recent onset of trismus, there is involvement of the infratemporal fossa. The base of the skull is involved. There is extensive soft tissue involvement and distance metastases are present. These are inoperable case. Now, after the operation of the surgery, reconstruction is also very important. Now, reconstruction of the mucosal defect can be done either by keeping it raw. If it is a small defect, it will granulate. Or if you could get a primary closure, try to primarily close it. In case of a larger defect, you could use a split thickness skin graft. Or a wider defect, you could offer a microvascular reconstruction with soft tissue. In case of reconstruction of the mandibular defect, they are anterior mandibular defect and posterior mandibular defect. You could use, in case of the anterior defect, you could use an osteocutaneous graft like free fibula osteocutaneous flap, radial forearm osteocutaneous flap, iliac osteocutaneous flap can be used in construction of anterior defect. Whereas posterior defect can be easily constructed with mucocutaneous flap like pectoralis major. Now the survival and prognosis. Now stage 1 and stage 2 oral cancer have a better prognosis. 5-year survival rate is seen in 30% to 100% of the cases. Where in advanced stage 3 and 4, very poor prognosis. 5-year survival in around 7 to 41% cases, that too depending upon the site of the tumor. Now, what is the role of we dentists, practitioners in case of oral malignancy? Now, we are the first one to early detect these cases. We can prevent the early pre-malignant condition if we diagnose them properly. We can do a preoperative dental workup for them. We could provide dental care preoperatively to starting of radiation therapy, patient education post-radiation therapy, and maxillofacial prosthesis fabrication after the surgical procedure and radiation therapy. Now with this, I would like to conclude by saying that oral cancer can be prevented through public health program in rural areas. Screening play a very important role in prevention, that too more commonly in rural areas. At the same time, surgical treatment, we also keep in mind to rehabilitate the patient, to restore the aesthetic function and speech, and also a long-term follow-up is a must. Thank you.